Hello and welcome. My name is Sebastian Probst. I'm a professor of tissue viability and wound care from the University of Applied Sciences and Arts, Western Switzerland, the University of Geneva, and the Geneva University Hospitals, Geneva, Switzerland. In this Smith+Nephew video, we are going to explore a concept that's becoming increasingly important in modern wound care, and that's shared care. Whether you're a nurse, a physician, a wound care specialist, or a caregiver, you're probably feeling the pressure, the time constraint, complex patient needs, and that persistent question of how do we truly make care better for our patients and ourselves. Shared care may be part of the answer. By the end of this session, you will be able to recognize what shared care is, along with its key concepts, person-centered care and self-management. But you will also be able to review a few ways you can implement shared care in your clinical setting and look at some best practices that can help us reclaim time, improve healing, and most importantly, serve patients better. But before we dive into that, we need to build a foundation. And that starts with two key concepts: person-centered care and self-management. Let's begin with person-centered care. Now, I know you've probably heard this term before. It's used a lot, but what does it really mean in practice? Person-centered care is about treating patients not as tasks or diagnoses, but as people. Individuals with goals, fears, preferences, and lives beyond their wounds. It's about shifting the focus away from just what's wrong with you to what matters to you. In wound care, this is critical. Patients often live with chronic wounds for months, sometimes years. The treatments can be painful, exhausting, and emotionally draining. We know from the literature, like the work by Corbett and Ennis, that patients want more than just complete competent treatment. They want to be heard. They want to participate in decisions. They want clinicians to listen to their pain, their routines, their worries. That's person-centered care, respecting the person, involving them in decisions, providing emotional support, coordinating across care setting, and involving their loved ones when needed. It's not just about being kind, it's about being effective. Because when people feel seen and valued, they engage more fully and outcomes improve. So now let's talk about self-management, a core part of shared care. Self-management means helping patients take an active role in their own care. That might mean changing their own dressings at home, or recognizing early signs of infection, or managing their pain or compression therapy routines, and definitely means understanding why these actions matter. But here's the challenge. Self-management doesn't happen automatically. It requires education, and not just handing out a brochure. I'm talking about structured, individualized support that builds confidence over time. That's what the WHO calls therapeutic patient education. It's practical, it's empowering, and it works, especially when it's personalized. Yet, many patients still don't know enough about their condition to take action. That's a gap we have to fill, and nurses are often the key educators here. When we support patients in managing their own wounds, We're not offloading responsibility. We're building partnerships. Now that we understand person-centered care and self-management, we are ready to explore shared care. So, what is it? Shared care is a model where responsibilities are shared between professionals, patients, families, and sometimes even digital tools. It's not about doing less. It's about doing things better. Imagine a well-coordinated team, the GP, the wound care nurse, the patient, their family, all working from the same plan with shared records, shared decisions, and mutual respect. Shared care has been successful in managing long-term conditions like hypertension, chronic kidney disease, stroke, and mental health. In wound care, it's gaining traction because it addresses exactly what makes wound treatment so challenging: complexity, fragmentation, and time. It helps us move from task-based care to team-based care. So what does shared care look like in wound care? Shared care in wound care looks like patients and families taking part in their daily wound care, nurses using their time for coaching, not just tasks, remote monitoring through telemedicine, and every member of the team, including the patient and their family, knowing what's going on. It's more connected, more coordinated, more compassionate, and it works. Patients feel more in control, clinicians feel less overwhelmed, and the entire system becomes more sustainable. How can we implement shared care? So now you might be wondering, this all sounds great, but how do we actually implement shared care in our practice? It's a fair question. And the truth is, implementation doesn't happen overnight, but it doesn't have to be complicated either. Here's a few starting points. Start with identifying patients for whom shared care is appropriate and who would benefit. Nurses can even scale up slowly, starting with patients in their current caseload who would be suited to this approach. Shared planning. Use care plans that are accessible to all patients, families, nurses, and doctors alike. Delegate with confidence. Train caregivers and patients to handle parts of the care safely, especially dressing, observation, or wound hygiene tasks. Use the tools you already have. Shared care doesn't always need new technology. A weekly call, text messages, a printed checklist, or even a shared wound diary can go a long way. Schedule smarter. That means long-aware dressings, reduce unnecessary visits, freeing time for education, not just execution. And finally, make a reassessment part of the routine in your clinical practice. Shared care only works when we continuously review what's working, what's not, and adjust together. Build partnerships. Trust is essential. That means listening more, asking patients what they feel ready to do, and supporting them as real partners in care. Remember, shared care is not a protocol. It's a philosophy with practical steps, and it's built around relationships. But let's not sugarcoat things. In real life, it's tough. Now let's look at a few best practices. Take, for example, Maria. She's living with a venous leg ulcer. After a few sessions with her nurse, she learned how to change her own dressings safely at home. Now, instead of coming to the clinic 3 times a week, she sends photos through a secure app for her nurse to review. This gives her sense of independence while keeping her care team fully involved. Or think of Ahmed, who has a diabetic foot ulcer. Through shared care education, he knows to check his foot daily for redness, swelling, or new drainage. When he notices even a small change, he contacts his clinic early, preventing a systemic infection and avoiding hospitalization. This is shared vigilance, where education leads to prevention. One of the biggest time sinks in outpatient wound care is dressing changes. According to the data, and this is from Moore and colleagues, up to 50% of outpatient nursing time is spent just changing dressings. That's hours and hours every week. Now think about what that means. Less time for education, less time for therapeutic conversations, fewer moments to address the person, not just the wound. And frankly, many of these dressing changes happen more often than necessary, not because of patient need, but because of routine or lack of alternatives. So what if we could change that? Here's where it gets exciting. Research shows that by using long-wear advanced foam dressing, we could potentially free up 3.5 billion hours of nursing time globally by the year 2030. Just imagine what we could do with that time. Instead of spending those hours on repetitive dressing changes, we could educate patients and carers, provide emotional support, monitor healing more strategically, focus on high-need patients, and build trust and therapeutic relationships. This is a small change with a big ripple effect, and it fits perfectly into the shared care model. Because shared care is about working smarter, not harder. Compression therapy can be challenging for patients with venous leg ulcers. In a shared care model, for example, the nurse doesn't just apply the bandage. They teach the patient and the caregiver how to apply and remove it safely, and how to spot when it's too tight or slipping. That shared confidence keeps the therapy consistent and effective. Let's close with a few takeaway points you can carry forward. Person-centered care is not an extra. It's the core of effective wound care. Self-management is a skill we need to teach, not assume. Shared care is a model that works, especially in chronic, complex conditions like wounds. Reducing dressing frequency through long wear options is a simple way to unlock time and improve outcomes. Implementation is possible, even in small steps. Shared care grows through communication, coordination, and trust. And maybe most importantly, we don't heal wounds. We support people as they heal. Shared care is how we do that together. This wraps up our Smith+Nephew presentation on shared care. Today we looked at what shared care is, along with its key concepts, person-centered care and self-management. We reviewed a few ways you can implement shared care in your clinical setting, and review at some best practices that can help you reclaim time, improve healing, and serve your patients better. I hope this will guide you in creating better outcomes and a better quality of life for your patients and informal carers. And make sure and check out our other titles on Smith+Nephew Academy online. I'm Sebastian Probst, and thank you for watching.